I want you to imagine, just for a second, walking into a really busy emergency room.
Oh, yeah. Always a stressful place to be.
Totally.
Yeah.
And let's say you've got a visibly broken arm, like the bone is fractured.
Yeah.
It's completely obvious. You're just holding it against your chest.
Right. There is no hiding that.
Exactly.
Yeah.
So they take an x-ray, and, a few minutes later, there's that jagged white line glowing right there on the screen.
Yep. The proof.
Yeah, the doctor points to it, you look at it, and there's this immediate, unspoken mutual agreement. The problem is real. It's right there in black and white, and now the medical team is just going to fix it.
It's an incredibly comforting dynamic when you really think about it.
Right.
Because, you don't have to convince anyone that your arm is broken. You don't have to, plead your case. The machine just did all the convincing for you.
Right. But now I want you to imagine walking into that exact same emergency room, maybe even on the exact same day, but this time you have a mysterious, agonizing internal ache.
Ooh, okay. That's a very different scenario.
Completely different. Maybe it's radiating down your lower back, or it's a sharp, stabbing sensation deep in your abdomen, but there is no jagged line on a screen.
No obvious fracture.
Nothing. There's no scan that highlights the area in glowing red.
Yeah.
You're just sitting on that crinkly paper on the exam table, and you realize something terrifying.
Which is, how do you prove it?
Yes. How do you prove what you are feeling to the doctor? How do you actually convince them of your reality?
And that scenario right there, the burden of proof resting entirely on the patient is one of the most profound, historically complicated challenges in modern healthcare.
Which is exactly our mission for this deep dive.
Yeah.
Today, we are looking at a massive and fascinating stack of clinical sources, all centered around pain assessment in nursing.
It's a huge topic.
It really is. We're going to explore why pain is universally referred to in medicine as the fifth vital sign, and why, paradoxically, it is the absolute only vital sign that completely and totally defies objective measurement.
Yeah, and it represents a fundamental shift in how we even think about clinical data. Think about the other 4 vital signs for a second.
Okay.
If a nurse needs to check your blood pressure, they just wrap a cuff around your arm and read the dial.
Super easy.
Right. And for your heart rate, or, your respiratory rate, they can literally just count the beats or the breaths.
Just looking at the clock.
Exactly. For your body temperature, there is a thermometer. But for pain, there is no external instrument.
None at all.
There is no cuff, no thermometer, no magical probe that you can just stick on a patient's forehead to get a neat, objective number.
Okay, let's unpack this, because on paper, if you've ever been to a clinic, a pain assessment sounds like the most straightforward task in the world.
Right, you just say a number.
Yeah. The nurse asks you a question, you give them a number, they write it down on a chart, and you move on to treatment. But what you're saying, and what these clinical sources are absolutely screaming at us, is that this seemingly simple act is actually a massive subjective challenge.
Precisely. It is incredibly messy. So let's start with the baseline clinical definition that's provided in the texts.
All right, lay it on us.
Pain assessment is defined as a systematic process by which a clinician identifies, characterizes, and quantifies a patient's pain.
Sounds very professional.
It does. And the goal there is basically twofold. First, to guide the immediate medical treatment, and second, to track whether that treatment is actually working over time.
Okay, but it sounds so clinical and tidy. Without a thermometer to do the actual quantifying, how does the system not just immediately break down?
Well, it doesn't break down, but the data has to pass through this incredibly complex filter.
What do you mean by filter?
Because there is no objective tool, pain assessment depends 100% on what the patient reports.
The human element.
Exactly. And that verbal report is filtered through so many messy human variables. It's filtered through language and vocabulary.
But you don't have the words to describe it.
Right. And it's filtered through culture, like how different cultures are taught to either express or, stoically suppress discomfort.
Oh, wow. Yeah, some people are taught to never complain.
Exactly. It's filtered through memory, through fear, and frankly, through the patient's level of trust in the person wearing the scrubs who's asking the question.
I was actually trying to think of how to describe this, and it's basically like trying to explain the exact taste of salt to someone using only words.
Oh, that is a great analogy.
Right. You know exactly what salt tastes like. It is a vivid, undeniable reality to you. But conveying that specific sensory experience to someone else is almost impossible.
It really is.
Except in this clinical scenario, your medical treatment, your literal relief from suffering, depends on how well you can describe the saltiness.
That's a lot of pressure on a patient.
But I have to push back a little here. isn't modern medicine supposed to be driven by hard, objective, empirical science?
In theory, yes.
So how does a purely subjective symptom, something that relies entirely on a patient's vocabulary or like their mood on a Tuesday, even fit into a rigorous scientific framework?
That is the million-dollar question. And to try and make sense of it, the sources frame the subjective challenge within a really robust landscape of clinical theory.
Okay.
To keep medicine scientific, the texts draw a very strict, definitive line between two concepts, nociception and pain.
Nociception, break that down for us, because that sounds like the hard science part.
It is. Nociception is the objective biological wiring.
Okay.
So when you accidentally touch a hot stove, nociceptors, which are these specialized sensory receptors scattered all throughout your body, they detect that extreme heat.
It's like little alarms.
Exactly. They immediately fire off an electrical signal that travels up your spinal cord to your brain, essentially shouting, "Warning, tissue damage is happening."
Gotcha.
That is nociception. It is purely biological, it's measurable, and it's objective. But pain is the conscious, emotional, and psychological experience of that signal once it reaches the brain.
Okay, so if I'm understanding this right, nociception is the computer hardware sending an error code, but pain is how the software actually experiences the crash.
That is a perfect analogy. The hardware sends the signal, but the software decides how much it hurts.
That makes so much sense.
And this concept leads directly into something called the gate control theory, which is really cool. It was proposed in 1965 by researchers Melzack and Wall. It's a foundational concept in the sources.
The outline mentions this, but how does this gate actually work in practice?
Well, think about what you instinctively do when you accidentally smash your shin against a coffee table or, you stub your toe. What is your very first reaction?
Oh, I immediately grab it and start rubbing it as hard as I can.
Exactly. Why do you do that?
I don't, it just feels like it helps.
Right, and gate control theory explains why. It proposes that the spinal cord contains this neurological gate that either blocks pain signals or allows them to continue on to the brain.
Wait, really? A literal gate?
A neurological one, yeah. So when you rub your stubbed toe, you are stimulating normal touch receptors. Those touch signals travel on fast, thick nerve fibers, and they literally reach the spinal gate first.
Beating the pain signals there.
Exactly. They effectively close the gate on the slower, thinner nerve fibers carrying the pain signals. You are physically blocking the pain by flooding the system with non-pain sensations.
That is incredible. So the pain isn't just a simple one-way street from the toe to the brain. It's like an active intersection where the body can actually modulate the traffic.
That's exactly it. And the gate can also be opened or closed by emotional factors.
Wait, emotions affect the physical gate?
Absolutely. If you are highly anxious, the gate opens wider, which amplifies the pain. If you are relaxed or distracted, the gate can actually close.
Wow.
This proves that pain is not just a biological event, it is inherently psychological as well. And because of this complexity, the sources categorize pain into distinct types.
Like acute and chronic.
Yes. There is acute pain, which is sudden and protective, like the twisted ankle that tells you to stop running.
Right, a useful warning system.
Then there is chronic pain, which persists for months or years long after the initial tissue healing is complete.
This is the warning system is broken.
Exactly. Chronic pain effectively loses its protective function. The alarm system is just stuck on. And finally, neuropathic pain, where the nerve fibers themselves are damaged and misfiring.
So that's the one that creates those burning or electric shock sensations.
Yes, even without an external injury.
So the medical field has created this incredibly dense, highly structured vocabulary. Nociception, gate control, acute, chronic, neuropathic, all to try and put a rigid scientific fence around something they can't actually see.
That's a great way to put it.
Which brings us to a historical pivot point that completely blew my mind while reading through these sources. We have to talk about Margot McCaffrey.
We absolutely do. If you want to understand modern pain assessment, you have to travel back to 1968.
Okay, set the scene.
Margot McCaffrey was an American nurse and an absolute pioneer in the field of pain management. And she published a definition of pain that changed the entire trajectory of modern healthcare.
The quote from the text is just brilliant. She wrote, in 1968, pain is whatever the experiencing person says it is, existing whenever they say it does.
It sounds almost too simple, doesn't it?
Yeah, a bit like a philosophical bumper sticker.
Exactly. But you have to understand how radically disruptive that was at the time. Historically, the clinician was the ultimate unquestionable authority in the room.
What the doctor says goes.
Right. If a doctor or a nurse looked at a patient who claimed to be in agony and the clinician thought, well, that surgical wound doesn't look that bad, or, they were just laughing at a joke on the television, they must not be in real pain.
Right. They just dismiss it.
Yes. The clinician's visual judgment overruled the patient's verbal report. McCaffrey's definition stripped that authority away from the clinician and handed it entirely to the patient.
She basically drew a line in the sand and said, your medical degree and your eyes do not get to overrule their lived reality.
Exactly. It made the patient the sole, undisputed authority on their own suffering.
That is powerful.
It really is. It forced the entire medical establishment to actively override their own human instinct to visually judge whether pain looks real. And the impact of that is staggering.
As it's still used today, right?
Yes. The sources note that McCaffrey's definition still appears, almost word for word, in nursing textbooks today more than 50 years later.
Okay, here's where it gets really interesting. Because McCaffrey's philosophy is beautiful, right? It's deeply empathetic.
It is.
But if the patient is the absolute, undisputed authority, what happens when the clinician's eyes and their years of medical training tell them something completely contradictory?
Right.
Let's say a patient tells a nurse their pain is a 10 out of 10, the worst pain imaginable, but they're sitting comfortably in bed, scrolling on their phone, eating a turkey sandwich. Doesn't this create a massive, unspoken tension right there at the bedside?
If we connect this to the bigger picture, that bedside tension you just described is exactly what sparked decades of systemic clinical evolution and, quite frankly, massive systemic consequences. Well, the sources highlight that this patient-first philosophy was the primary engine behind a massive policy rollout between 1995 and 2001. That was the era when medical institutions and accreditation boards officially branded pain as the fifth vital sign.
Meaning that hospitals were suddenly, federally and institutionally mandated to check and treat pain as routinely as they checked a patient's pulse.
Yes, the intent was incredibly noble, to ensure that patient suffering was never again ignored, dismissed, or undertreated.
Which is a good thing.
Of course. But the sources are very clear that this well-intentioned policy, when combined with a complete lack of objective measurement tools, created a highly volatile landscape. We see this tension feeding directly into the history of the opioid crisis.
Oh, wow. Let's follow that mechanical logic because it makes terrifying sense.
Right.
If the institutional mandate is that you must treat whatever the patient says they feel, treating the pain until it reaches zero.
Yes.
And the primary, most effective tool you have in your medical arsenal is an opioid, then prescription rates are going to absolutely skyrocket.
Exactly. You had an objective, powerful medication being mass prescribed to treat a completely subjective symptom, driven by a mandate that said the provider could not question the patient.
That's a perfect storm.
It really was. The texts present this as a critical historical reality, that the absence of an objective thermometer for pain actively contributed to how pain was managed, for better and for worse.
We're talking massive societal impact here.
Yes. And the sources are careful to just impartially report this. And similarly, they highlight that this inherent subjectivity is exactly where interpretation disparities and racial biases in pain treatment take root.
Right, because if you don't have a blood test to prove the pain and you are relying entirely on a human filter to report it, you are also relying heavily on the human filter of the provider to interpret it.
Correct. When data isn't objective, subconscious assumptions fill the gaps. The sources document that because pain cannot be objectively verified, a provider's implicit biases regarding race, gender, and socioeconomic status can heavily influence their decisions.
Like whether they actually believe the patient?
Exactly. Whether they truly believe a patient's self-report or how aggressively they choose to treat it. Study after study in the sources shows that minorities, particularly Black patients, are frequently undertreated for pain compared to white patients with the exact same ailment.
That's just awful.
It is. The documents impartially report that these massive systemic issues, both the skyrocketing prescriptions of the opioid crisis and the tragic disparities in care, are inextricably linked to the structural reality that pain assessment requires trusting a subjective report.
It's incredible. It all flows downstream from the simple fact that we don't have a pain thermometer.
Yes, it all comes back to that.
Which brings us to the other major player in the sources, McCaffrey gave us the nursing philosophy, but the International Association for the Study of Pain, or the IASP, gave us the institutional definition.
Right, the official global standard.
So in 1979, the IASP defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage.
And that definition, word for word, stood unchallenged as the global medical standard for over 40 years.
But wait, I have to point out a huge logical flaw here. McCaffrey says pain is whatever the person says it is. The 1979 IASP definition relies on the experience being described in terms of tissue damage.
Right.
Both of these cornerstone definitions completely rely on the patient being able to communicate. What happens when the person literally cannot speak?
And you've just zeroed in on the exact ethical and clinical dilemma that forced the IASP to finally act.
Oh, real?
Yeah. In 2020, they took the highly unusual step of formally revising their global definition. It was only the second time in the organization's entire history that they did so.
That is a huge deal for a global medical institution. They don't just rewrite the dictionary on a whim.
No, they don't. They kept that core 1979 sentence intact, but they added 6 crucial, game-changing, clarifying notes.
Okay, what were they?
Well, 2 of those additions directly answer your question about the voiceless. The first critical note states, a person's report of an experience as pain should be respected.
Ah, so that's a formal global nod to the McCaffrey philosophy.
Exactly. But the second addition is the most vital. It states that the inability to communicate verbally does not negate the possibility that a human or a non-human animal experiences pain.
Oh, wow. So they explicitly, formally broadened the definition to protect the vulnerable. They took the burden of proof off the patient's voice.
Exactly. And the clinical impact of this cannot be overstated. The sources emphasize that this 2020 revision wasn't just some dusty academic exercise.
See, it had real-world teeth.
Absolutely. It was
Yeah.
a direct, urgently necessary response to decades of medical fields systematically undertreating pain in populations that couldn't advocate for themselves.
Because if the patient couldn't speak or couldn't accurately describe the tissue damage, the clinical assumption was often, well, they must not be in that much pain.
Tragically, yes. And we are talking about infants. For a surprisingly long time in medical history, it was incorrectly assumed that infants didn't experience pain the way adults do.
Wait, what?
Yeah, the theory was that their nervous systems were immature, so procedures were sometimes done with minimal analgesics.
That is absolutely horrifying to think about, that we just assumed a crying baby wasn't actually experiencing agony just because they didn't have the vocabulary to tell us.
It's a very dark chapter in medical history, and the 2020 revision directly combats that legacy.
I would hope so. Who else does this protect?
We're also talking about elderly people with advanced dementia. They might be suffering from a urinary tract infection or a fracture, but can't articulate what's wrong. They might just become agitated or withdrawn.
Right, because they can't say it hurts.
Exactly. And we're talking about patients in the intensive care unit who are heavily sedated or intubated with a breathing tube who physically cannot speak. The 2020 revision mandates, on a global scale, that their pain is real, it is valid, and it absolutely must be assessed, even without words.
So what does this all mean? How do we actually do that?
That's the practical challenge.
Right. If I am a nurse working a 12-hour shift and I have a patient who is in pain or a patient who cannot speak, how do I implement these high-level philosophical definitions? I can't just ask, how much does it hurt, and leave it at that.
No.
Yet there has to be a framework. What are the actual tools of the trade to bring form to the subjective?
To bridge that immense gap between a subjective human experience and an objective, actionable medical chart, the field created very specific methodologies. The sources highlight a foundational first principles approach known as the PQRST method.
PQRST, it's an acronym. Walk us through how a nurse actually uses this at the bedside.
Sure.
Let's say I come into the clinic complaining of stomach pain.
Right, so the nurse doesn't just ask if it hurts. They conduct a structured interview to extract actionable data.
Okay, let's hear it.
P stands for provocation or palliation. They will ask you, does taking a deep breath make the stomach pain worse? Does leaning forward make it better?
Ah, finding the triggers.
Yes. Q is for quality. They need you to describe the sensation. Is it a sharp stabbing pain or a dull burning ache?
Because a burning ache might mean an ulcer, but a sharp stab might mean appendicitis.
Exactly. Then R is for region and radiation. Show me exactly where it hurts. Does the pain travel up to your shoulder or down into your groin?
Mapping it out.
Right. S is for severity, which we'll talk about with the scales in a moment. And T is for timing. Did this start suddenly an hour ago, or has it been a slow build over 3 weeks? Is it constant, or does it come and go?
It's brilliant. It is essentially forcing a chaotic personal narrative into a highly structured clinical data set. You're giving the patient a standardized vocabulary test to help you understand the invisible.
That's a really good way to frame it.
But let's talk about the S severity. That's where the famous pain scales come in, right?
Yes. And because patient populations are so diverse, the texts detail several distinct pain scales. The most common one, the one you and every listener has probably encountered, is the NRS, or numerical rating scale.
Okay, the classic 0 to 10.
Right, that's the classic. On a scale of 0 to 10, with 0 being no pain and 10 being the worst pain imaginable, where are you right now?
Which, again, relies on that human filter. My 7 might be your 4, a paper cut to me might be a 3, but to a carpenter it might be a 0.
That's true, but the genius of the scale is that it establishes a baseline for you.
How so?
If you come in reporting a 7, the nurse administers medication, and an hour later you report a 4, the objective reality is that the treatment is working for your specific neurobiology.
It's relative to the individual.
Exactly. Now, for pediatric patients or adults with cognitive or language barriers, there is the FACES scale.
Oh, I know that one. That's the one you see in the pediatrician's office with the cartoon faces drawn on it, ranging from a happy, smiling face on the left to a red, crying face on the right.
Yes, exactly. The patient doesn't need to understand numbers. They just point to the face that matches how they feel inside.
Makes total sense.
But what about the patients we just talked about, the babies, the intubated, the advanced dementia patients?
The ones who can't point.
Right. That is where observational scales come in. The sources highlight the FLACC scale, which stands for face, legs, activity, cry, consolability.
Walk me through that. How do you score someone who can't speak? Let's use a 6-month-old infant recovering from surgery.
Okay, so instead of asking the infant, the nurse becomes a highly trained observer. They watch the infant for a set period.
Okay.
Face, is the baby relaxed, or are they grimacing with a furrowed brow? Legs, are the legs relaxed, or are they drawn up tight to the chest, which indicates distress?
Oh, right. Babies do that when they're upset.
Exactly. Activity, are they lying quietly, or are they thrashing around? Cry, is it a whimper or a steady screaming cry? And consolability, if the parent holds and rocks the baby, they calm down, or are they completely inconsolable?
Wow. So the nurse assigns a point value to each of those physical behaviors, tallies them up, and that generates the pain number for the chart.
Correct. There is also the pain add scale, specifically designed for pain assessment in advanced dementia. The nurse observes breathing patterns. Are they hyperventilating? They listen to vocalizations. Are they moaning or calling out?
Looking for physical cues.
Yes. They look at body language. Are their fists clenched? Even though there is no single thermometer for pain, these tools represent a rigorous, deeply scientific, and profoundly empathetic attempt to measure it anyway.
This raises an important point for you listening right now. The next time you're in a clinic or a hospital and a triage nurse asks you to rate your pain on a scale from 0 to 10, you should realize what is actually happening in that room.
It's so much more than a number.
Right. You aren't just answering a simple intake question. You are actively participating in a system that is built on over 50 years of intense philosophical debate, a highly contested history of medical evolution, and a profound shift in clinical power dynamics.
This raises an important question. How do we balance correcting historical clinical misconceptions with the real-world stakes of patient care today?
Yeah, how do we?
Well, relying on these tools, the PQRST method, the numerical scales, the observational charts, isn't just about a nurse checking a box or charting a number for insurance compliance. It's about honoring that 2020 IASP mandate.
Respecting the experience.
Yes. It is a systematic, daily attempt by the medical community to respect the patient's lived experience, whether that patient is speaking clearly, pointing at a cartoon face, or lying silently in an ICU bed.
And it really traces all the way back to people like Melzack and Wall in 1965, who first proposed that gate control theory.
They really started it all.
They were trying to prove that pain wasn't just a simple one-way street of biological hardware, but an incredibly complex intersection of mind, body, emotion, and environment.
They absolutely set the stage. Their science paved the way for Margot McCaffrey in 1968 to demand that we listen to the patient's voice, which in turn set the stage for the IASP in 2020 to demand that we listen even when the patient has no voice.
It's an incredible evolution.
It's an evolution of human empathy, practically disguised as routine medical procedure.
It really is. To briefly recap this incredible journey we've been on today, we started by looking at a vital sign that you literally cannot measure with a machine.
Nope.
We explored Margot McCaffrey's radical demand to trust the patient's truth above the clinician's eyes. We navigated the turbulent downstream effects of that subjectivity, from the well-intentioned policy shifts to the massive systemic debate surrounding opioids and care disparities.
A lot of unintended consequences there.
Definitely. And finally, we saw how the modern medical field uses specialized scales and methods like FLACC and PQRST to bridge the gap between invisible suffering and actionable science.
What's fascinating here is that nursing, at its very core, fundamentally requires operating in this ambiguous gray area.
Yeah.
It requires taking rigorous, structured, systemic assessment tools and applying them to a totally invisible, entirely human experience. At the end of the day, pain assessment is science boldly attempting to quantify suffering.
And doing so knowing full well that the tools are inherently imperfect, but absolutely necessary for compassionate care. Which leaves me with a final slightly sci-fi thought for you to chew on before we go.
All right.
Our entire current understanding of pain assessment, everything we've talked about today, relies on trusting the human report. We trust the voice, and we use observational tools precisely because we lack an effective thermometer.
Right.
But what happens in the near future if advanced brain imaging or AI actually does allow doctors to objectively read our pain levels?
That would change everything.
If a machine could finally map the exact severity of that invisible ache in your spine and project a definitive number on a screen, would we even want it to have the power to override our own voice?
That is a deeply unsettling, yet probably inevitable question for the future of medicine.
Think about that the next time they ask you for a number. Thanks for diving deep with us today.